Hi, everyone. Welcome to the fourth module, Health Equity in Rare Disease, Stories, Data, and Solutions. I'd like to thank Robin Shapiro and Dr. Nicole Rochester from Health Advocate X for inviting me to speak on this very important topic. Thank you all for joining me. Before we begin, let's review the learning objectives. To understand why and how it takes so long to be diagnosed with rare disease and why the journey is different for people of color and families with limited resources, why equity matters in rare diseases, and to be able to name and remember examples of diagnostic bias to help ensure advocates are looking for this in a patient's diagnostic journey. I'm Dr. Maggie Kong. I am a physician turned resilience and healthcare coach, rare disease advocate, and speaker after my daughter was diagnosed with a rare disease at age 9. Here is a little bit about us. I've had the honor of sharing my TEDx talk about my journey as a mom caregiver in rare diseases, hoping to inspire others facing similar challenges. My daughter Nell wrote a book about her experience when she was diagnosed with her rare disease. It's called My Hospital Story, which is a heartfelt account of her experience in the hospital. With the book, she aims to support and give voice to children and teens living with rare diseases. Her story and the publication of her book were covered on the CBS Evening News. We also became rare disease advocates and are ambassadors to the Sumire Foundation for Neuroimmune Diseases. Here we are as moderators for panels at a patient day at UCLA hosted by the Sumire Foundation. We've also participated and advocated at Rare Disease Week on Capitol Hill for the past 3 years. Here we are in the Senate building waiting to speak with Senator Mark Warner of Virginia. And down below is a picture of Nell standing in the Capitol waiting to speak at a rare artist event hosted by the Every Life Foundation. These are slides of what my daughter looked like before her diagnosis. Nell was born healthy and was a very vibrant and energetic child who was actually really sick. So she went from running down a lacrosse field and celebrating a victory, screaming with her teammates, to lying helpless in an ICU bed, practically overnight. I remembered the night my daughter was admitted into the ICU. Seeing her so vulnerable and frightened was heartbreaking. That moment changed everything for me. It made me realize how fragile health can be. When my daughter first got sick at age 9, she was diagnosed with neuromyelitis optica spectrum disorder. It was the first time, it's also called NMOSD. And this was the first time we experienced what so many people experience in the rare disease community. So Nell's disease, this NMOSD, is rare, it's incurable, and it's neurologic, and it's autoimmune, and it affects the spinal cord, brain, and optic nerves. Depending on where the disease manifests determines whether or not a patient presents with paralysis, blindness, and if it impacts the brainstem area, it typically presents with nausea, dizziness, fatigue, hiccups, and paralysis. Let's see. So sorry. This is a picture of Nell in the hospital, actually, with the dog on her bed at Children's National. So basically, when she was presenting with the symptoms of nausea and dizziness and significant fatigue, we went through weeks of uncertainty, doctor visits, tests, wrong turns, and far too many we don't knows. Then, when her disease progressed to a point when she couldn't get out of bed, we had to take her to the emergency room one dark, cold night in January 2018. I was essentially carrying her through the parking lot because she was that fatigued and weak. My daughter was admitted and stayed in the pediatric ICU for many weeks. What I didn't realize at the time was that our experience was not unusual. So just some basic facts about rare diseases. Globally, we know that there are over 6,000 rare diseases affecting 300 million people. So that's about 30 million in the United States. And we also know that the average time to diagnosis is about 7 to 8 years. So that means 7 years of bouncing between specialists, 7 years of unnecessary procedures, 7 years of being told it might just be stress. But here is the deeper problem. Those 7 years aren't distributed equally. Women, patients of color, and families with limited resources wait even longer for answers and sometimes never get them. And the costs are staggering. A landmark study done by the Every Life Foundation found that the economic burden of rare diseases in the United States exceeds $1 trillion every single year. Much of that is tied to misdiagnosis, delayed treatment, and preventable complications. So when we talk about equity in healthcare and rare disease, we're not talking about an abstract concept. We are talking about whether patients live or die, find answers, or remain invisible. Every year, millions of people living with rare diseases face the same challenges, not just their condition, but the inequities in how healthcare sees, hears, and treats them. My hope is that today's conversation sparks awareness about the urgent need for equity in healthcare. We must dismantle the barriers that delay diagnosis and deny patients the care they deserve. Every story like Nell's reminds us that behind every statistic is a real person, a family, a future waiting to be unlocked through understanding and action, as perhaps you or your loved one. Today, I'm going to discuss the challenges further and suggest solutions to create change. I'd like to break down this conversation about health equity into three levels: the systemic, the healthcare provider level, and the individual self-advocacy level. But first, as I make the case for change and why equity matters in healthcare, let's look at two powerful examples of well-known systemic biases to understand why equity is critical. First, Black maternal mortality is very well studied and documented. Black women are 3 to 4 times more likely to die from childbirth than white women. This disparity persists regardless of income or education. And tragically, the CDC finds over 80% of these deaths are preventable, pointing directly to systemic failures. Pain bias. Patients of color are systematically undertreated for pain. Black patients are 40% less likely to receive pain medication in ER than white patients. And this bias is consistent across Black, Hispanic, and Asian patients, even when controlling for pain severity. These aren't isolated issues. They are symptoms of a system where outcomes are shaped by race and ethnicity, not just clinical need. So, why do these statistics matter for rare disease? We've seen how inequity harms maternal health and pain management. Now, imagine those same biases amplified within the fragile world of rare disease, where diagnoses already take years to find, specialists are few, and treatment options are scarce. The cost of delay. Each year of diagnostic delay adds massive downstream costs. ER visits, unnecessary procedures, loss of productivity. Nearly half of the $1 trillion rare disease burden comes from these indirect costs. The inequities, they don't just add up, they amplify in these four ways for the rare disease population: diagnostic bias, pain bias, access and coverage gaps, research representation. So let's now delve deeper into each. First, let's talk about how diagnostic bias is amplified in rare diseases. So, Once again, revisiting what has been very well studied in maternal health, research shows that Black women are at least 3 times more likely to die from pregnancy-related causes compared to white women. So a significant reason for this alarming disparity is the way symptoms are often dismissed or not taken seriously. So for example, when Black women report pain and other symptoms, their concerns are often downplayed or attributed to less serious causes, leading to delays in diagnosis and treatment. This bias not only prolongs suffering, but can have tragic and often fatal consequences. It's a clear example of how inequities impact health outcomes and underscores the urgent need to address implicit biases within healthcare. In the realm of rare diseases, the same pattern of bias becomes even more devastating. Because rare diseases are inherently difficult to diagnose, even for experienced specialists, any underlying biases can further slow the process. So, the parallel message is that if bias and dismissiveness cost lives in something as common and familiar as childbirth, imagine how much more harm they cause in conditions that most healthcare providers have either very little experience with or have no awareness at all. When bias is embedded in the system, the impact is amplified in populations already vulnerable due to socioeconomic or racial disparities. Pain bias. Again, we already know that pain in patients of color is systemically undertreated and dismissed. This disparity is driven by a range of factors, including implicit bias, stereotypes about pain tolerance, and systemic inadequacies in addressing cultural differences. As a result, their pain reports are often dismissed or undertreated, leading to inadequate care and delayed diagnoses. This not only causes unnecessary suffering, but also contributes to mistrust in the healthcare system, which can have long-lasting consequences for ongoing treatment and engagement. So how is pain bias amplified in rare diseases? Because pain is often a key early symptom. Dismissing it as stress or maybe drug seeking prevents investigation into the underlying serious condition and sometimes missing that very important window for effective treatment, which could dramatically alter a patient's prognosis. It underscores the urgent need to confront biases, not just in pain management, but across all aspects of healthcare, so that every patient's symptoms are validated and thoroughly investigated. This dismissiveness pushes patients deeper into what's known as that diagnostic odyssey, a long and frustrating journey marked by misdiagnoses, unnecessary tests, and a profound sense of helplessness. Now let's talk about access and coverage gaps, which are also amplified in rare diseases. So again, looking back at that data around Black maternal health, preventable deaths often occur in low resource, rural, or Medicaid insured hospitals lacking resources and emergency care. So this leads to unsafe delays in treatment and tragic outcomes. In the rare diseases, genetic testing and specialists and experimental therapies are costly and often inaccessible, especially for rural or low-income families, deepening existing inequities. So the parallel messaging is that the disparities in maternal health driven by resource gaps are amplified in rare disease care, where complex, expensive, and often inaccessible treatments turn these inequities into life or death issues. Let's talk about research representation and see how that is also amplified in rare disease. So back to the maternal health. Black women's experiences have long been under-researched and overlooked, contributing to disparities in care. In rare diseases, clinical trials already face challenges with small sample sizes, given the inherent rarity of the diseases. When patients of color are underrepresented, treatments may be developed without understanding their effectiveness across diverse populations. So the parallel messaging is that lack of representation in rare diseases isn't just a fairness issue. It directly affects who benefits from new treatments. With every small trial sizes in rare diseases, a lack of diversity means we don't know if the new treatments work for all populations. So now that we understand how the many challenges faced by people of color in common scenarios are amplified in rare diseases in terms of diagnostic bias, pain bias, access, and research, let's look at these health equity challenges more specifically in the experience of the rare disease community. I like to break down this very complex topic into three sort of levels or perspectives: the systemic, provider, and the individual self-advocacy levels. For each, I will share a story to illustrate the challenges from that perspective and then offer my proposed solutions. Let's start with the systemic perspective. So there's a little boy in rural Texas. His parents don't speak much English and they live hours away from the nearest children's hospital. He starts having symptoms no one can quite explain. The pediatrician suspects something rare, but here's the catch. In his state, Medicaid doesn't fully cover genetic testing. His family waits. They scrape together money. They make phone calls, but weeks turn into months. By the time he's finally diagnosed, they have traveled across 3 counties, lost wages from missed work, and his condition has worsened. The truth is, his delay in care wasn't about the science. It was about the system. Where he lived, the language his parents spoke, and how his insurance policy was written determined his timeline to diagnosis. That's not just a medical story. It's a story about equity. And it reminds us that equity in healthcare at the systemic level means asking who is being left behind by the way our system is designed. So this story highlights some of the systemic inequities in rare diseases. First, insurance gaps. Coverage for genetic testing varies widely depending on where families live and their insurance plans, whether it's Medicaid or private insurance. In many states, genetic testing, which is often essential for diagnosing rare diseases, may not be covered at all, forcing families to pay thousands of dollars out of pocket. This financial barrier can delay diagnosis even further, especially for low-income families who may already struggle to afford these critical tests. Geographic inequities. About 70% of rural United States counties have no geneticists at all, creating diagnostic deserts. And this means families living in these deserts or these areas that have little or no access to specialized care, they need to identify and treat these diseases promptly, but without local experts, patients must travel long distances, sometimes hundreds of miles to see a specialist, which can be costly, time-consuming, and logistically impossible for many. Research representation. This is not directly shown in the story, but patients of color are significantly underrepresented in rare disease clinical trials. This lack of diversity in research means that we may be missing critical insights, since biological differences can influence how diseases manifest and how treatments work. So, without inclusive data, we risk developing therapies that may be less effective or even harmful to underrepresented populations, deepening healthcare disparities. Finally, the economic toll is also seen in systemic inequities. Rare diseases imposes a staggering economic burden, costing again the United States nearly $1 trillion annually. Much of this comes from preventable complications, long-term care costs, lost productivity. When diagnosis and treatment are delayed or inadequate, patients face worsening health outcomes, driving up costs for individuals, families, and society as a whole. So, why does all of this matter? Inequity is not just about fairness, it is about outcomes and costs for everyone. Delayed diagnoses leads to longer hospital stays, more ER visits, and higher costs for insurers and taxpayers. Preventable costs like complications and late-stage interventions burden the entire healthcare system. In other words, we all bleed red, and inequity makes care more expensive for everyone. So here's the question that I'd like to address. How do we design healthcare systems that distribute resources equitably so rare patients aren't left behind due to zip code, race, or socioeconomic status? Here are some of my proposed solutions. Let's dig deeper into each. For insurance and coverage gaps. Coverage for genetic testing, as I said, varies widely depending on where families live and their insurance plans, whether Medicaid or private insurance. This financial barrier can delay diagnosis even further, especially for low-income families. So, here are some solutions that I have proposed. Standardize insurance coverage for genetic testing across Medicaid and private insurance, recognizing that these tests are medically necessary, not elective. Let's engage industry support, expand patient assistance programs where nonprofits or biotech companies can subsidize genetic testing for uninsured families. And let's create telegenetics programs so we can increase access through telehealth genetic counseling to reduce costs and travel, making testing and interpretation more accessible for everyone. Geographic inequities. About 70% of rural United States counties have no geneticists at all. So we're creating these diagnostic deserts. So without the local experts, patients have to travel long distances, and like in our story, it costs time and job loss, and when they need to see a specialist, it can be so costly and so logistically impossible for many. So why don't we expand telehealth? We can build rare disease telemedicine hubs that connect patients in these diagnostic deserts to specialists in major academic centers. Let's create mobile clinics and outreach. We can partner with children's hospitals or academic centers to run mobile diagnostic units that bring genetic testing and specialist consultations to rural regions. And let's create state incentives, offer loan repayment or grants to genetic counselors or specialists who serve in rural areas, similar to already existing programs for the primary care shortage in these areas. Research representation. So as I said before, patients of color are significantly underrepresented in rare disease clinical trials. So without inclusive data, we risk therapies that may be less effective or even harmful to these underrepresented populations. So I think we can create these diversity mandates in trials, and we can require NIH and FDA-funded rare disease research to recruit participants across racial and ethnic groups, not just convenient samples. We can do community-based recruitment, partner with trusted community organizations like churches or advocacy groups, local clinics, to build trust and awareness about these trials among underrepresented groups. And I thought we could fund patient navigators who can help these underrepresented patients enroll and remain in these clinical trials by addressing logistical challenges like transportation and getting childcare. So the economic toll, as I mentioned, is staggering. Nearly $1 trillion every year. And when diagnosis and treatment are delayed or inadequate, patients face worsening health outcomes. It's driving up costs for individuals, families, and societies as a whole. So, what can we do to improve that? We know that early diagnosis equals cost savings. So let's implement policies that recognize timely genetic testing and early interventions as cost saving measures, reducing avoidable ER visits and long term disability costs. Let's talk about integrated care models, like expand the use of multidisciplinary clinics, sort of like a one-stop center for geneticists, social worker, mental health worker, and specialty care and all the doctors. This can improve outcomes and lower costs through coordinated care. I mean, can you imagine having to take time off to go and visit each one of these appointments separately? It's a lot of time and money. I would love to also get public data transparency. Require insurers and healthcare systems to publish cost data showing where delays increase costs, creating accountability for addressing preventable expenses. When we think about equity in rare diseases, at the systemic level, it's not just about culture or sensitivity training. It's about designing systems that distribute resources equitably. Because the truth is, equity doesn't just cost patients, it costs all of us in lives and dollars wasted. So now let's shift to the provider relationship perspective. A young Black woman with a rare autoimmune condition goes to the ER again and again with severe eye and head pain, lower extremity weakness, and fatigue. Each time her symptoms are dismissed: stress, anxiety, maybe depression, no labs, no imaging, just reassurance to rest. Months later, when she finally sees a specialist, the truth comes out. Her disease has progressed to the point of permanent disability. She is nearly blind, unable to walk, and needs long-term care. That delay in diagnosis didn't just cost her health, it cost the system too. Years of lost wages, disability benefits, and more intensive, expensive treatment that could have been avoided. Her story is not rare, it's systemic. So let's look at some of the challenges or barriers, sorry, in this particular story. Implicit bias is the unconscious attitudes or stereotypes we hold that influence how we perceive, interact with, and make decisions about others without often realizing it. When providers unconsciously hold stereotypes or biases, they downplay symptoms or dismiss concerns, which leads to delays in diagnosis and treatment. This not only causes unnecessary suffering, but also widens health disparities. Similarly, communication gaps, like language differences and cultural misunderstandings or assumptions made by healthcare providers, can undermine trust between patients and clinicians. When communications break down, patients may feel unheard and misunderstood, leading to delays in seeking care. And these gaps can significantly slow down the diagnostic process and diminish the quality of care. Also, there's this algorithmic thinking. This is the way that we're trained to think about patient care. So we rely as physicians and healthcare providers on pattern recognition, matching symptoms to textbook cases to diagnose conditions, and following the path to a diagnosis and following management. However, patients with rare diseases often don't fit into the classic presentations and they may have atypical symptoms. So, relying solely on these patterns can result in misdiagnoses or delayed diagnoses, especially when biases influence which symptoms are prioritized or dismissed. Unusual cases can sort of not even be considered because they're not sort of fitting the mold. And this approach can unintentionally cause clinicians to overlook or misinterpret complex or unfamiliar cases. I just want to share very briefly an experience I had when I was a medical intern, and a South Asian woman presented to the ER with fatigue and shortness of breath and back pain. And so, because it wasn't the classic chest pain, I didn't consider a heart attack, which in fact it was. And so, my attending taught me that sometimes South Asian women just present atypically, and it's been a sort of research and well known at the time. And by adjusting our clinical thinking or our algorithm to include all of these presentations, we could catch and make these diagnoses earlier and impact outcome. So, this is an example of an atypical presentation of a very common diagnosis. So you can only imagine how diagnosing even a common presentation of a rare diagnosis can pose challenges. And so if we don't sort of include rare presentations in our algorithmic thinking, I think we have the tendency to sort of dismiss and not even sort of consider these outlier diagnoses. Equity at the provider level isn't about political correctness. It's about accuracy, safety, and cost. It means training clinicians to recognize bias, listen deeply, respect patient narratives, especially when symptoms don't fit textbook patterns. Because when bias intersects with a 7-year diagnostic odyssey, the result isn't just worse care, it's potentially catastrophic care. So when we look to solve problems, it's good to ask the right question. And here is the question for this section. How do we train clinicians to recognize bias, listen deeply, and respect patient narratives to improve diagnostic accuracy, safety, and healthcare costs? Here are my proposed solutions. Let's see. So let's talk about bias awareness and building that into clinical training. So to create lasting change, we need to incorporate equity training directly into medical education. This can be done through micro trainings and continuing medical education requirements, just using these very short, focused sessions that use real life case examples. And so by raising awareness of unconscious biases early and often, clinicians, we can recognize and counteract them in our practice. And we could do training to improve communication gaps, expand access to trained medical interpreters and culturally competent care navigators so patients can communicate clearly in their preferred language and cultural context. We can offer provider training in cultural humility so clinicians learn to ask open-ended questions, check understanding, and avoid assumptions. And just sort of like a quick review to differentiate cultural competence versus cultural humility, because sometimes it hasn't always been that clear to me. Competence assumes I can learn enough about your culture to understand and serve you. Humility assumes I may never fully understand your culture, but I can listen, learn, and adapt with respect. And finally, I think we can create partnerships with specialty organizations. Working with emergency room doctors, pediatric groups, and different residency specialty programs, I think is vital. Through these partnerships, especially the ER, because this is often the first place people present with symptoms, we can embed bias awareness and rare disease education into clinical guidelines and training materials. The goal is to equip frontline providers, such as ER doctors, urgent care clinicians, and primary care physicians with the tools and knowledge they need. And it would also be great if we could initiate this training not only in residency programs, but as early as medical school. Just something to think about. So summarizing this section on the provider perspective, I think equity is about sharpening, not softening our practice. When we train to listen more deeply and check bias, we don't just create more equitable care, we make better clinical decisions. And in rare diseases, that difference can mean years of preserved function, millions of dollars saved, and lives transformed. So, oh, I'm sorry, I didn't. Ugh. So we're now at the individual self-advocacy perspective. Sorry, I think I got delayed on one of those slides. A first-generation Asian college student is newly diagnosed with a rare inflammatory disease. At first, every appointment feels like a foreign language. Doctors use acronyms she doesn't understand. Her parents get overwhelmed with insurance paper, and treatment plans shift constantly. She and her family, excuse me, are confused about when to schedule follow-ups, how to set up labs, so they miss appointments and the timing of labs. I mean, some labs require fasting, some labs require being present at a certain time relative to the medication. So she starts keeping a binder, lab results, insurance letters, notes from every visit. She practices explaining her condition in doctor language so she won't feel brushed off. Over time, she grows more confident, and eventually, she's not only advocating for herself, but also speaking on panels for other patients. And what started out as survival becomes a story of empowerment. Now, this story highlights both the challenges and a lesson in individual self-advocacy. Let's talk about the lesson. This patient story shows how equity at the individual level also means empowering patients and families to move from being passive recipients of care to active partners in shaping it. Now, as for challenges, one of the ongoing struggles faced by patients navigating rare diseases is not only language barrier, but also understanding medical jargon. Medical terminology can be confusing and intimidating, especially when patients are already overwhelmed by their health concerns. And this complexity makes self-advocacy significantly harder because patients may not fully understand their diagnosis or the questions they need to be asking their providers. And without clear communication, patients cannot effectively voice their needs or seek the appropriate care. And obviously, on top of that, the language barrier magnifies those challenges. So this is, of course, adding to the challenges of like the staggering average delay of 7 years of correct diagnosis in rare diseases. And during those years, patients can learn to ask, I guess, better questions to push for further testing and get specialist referrals. And they might hear, that it's stress or it's anxiety repeatedly without ever being told about the possibility of a rare condition, which prolongs the diagnostic journey. And so I can understand how this creates enormous frustration and fear and unnecessary suffering. And so I think that the missed or delayed diagnoses can lead, well, they definitely can lead to irreversible disability and preventable suffering and higher costs to the healthcare system because of these repeated tests and ER visits and ineffective treatments. Research actually supports the importance of patient activation. When patients are engaged, ask questions, and advocate for themselves, they tend to have 8 to 21% lower healthcare costs and better health outcomes, according to a study in Health Affairs by Hibbard. This highlights the critical role that self-advocacy can play. Yet, marginalized groups are less likely to access patient support resources due to awareness gaps, stigma perhaps, and systemic barriers. So here is the important question to ask. How can we empower patients and families to move past being passive recipients of care to active partners with healthcare providers? Here are some of my proposed solutions. So, this is actually the space I largely work in right now, where I support patients and caregivers to become strong advocates. So, I want to spend the remainder of this time talking about individual self advocacy. And this is not at all to increase the burden of responsibility on patients and caregivers, but because the changes at the systemic and provider level are not directly within our control right now, and it will likely take time to affect changes on these levels, especially with our current administration. I wanted to talk about what we can do today from an individual self advocacy perspective. So let's delve into these more deeply. Empowerment through organization. Empowering patients begins with helping them to identify and clearly articulate their needs, values, and fears. And this process can be supported by encouraging patients to actually just organize their medical information. It's that in and of itself can really lift sort of the heavy burden of worry. So creating a comprehensive health journal or binder or using a note-taking app like Evernote is what I use, or an actual patient data app like Mijo. I'll just actually keep this section brief because I know other people are covering this topic in the other modules. But just sharing my insights as a physician, I think that keeping track of these symptoms, the treatment histories, test results, and questions, patients can have a better understanding of their health landscape. And it's also important to know like which pieces of medical data are relevant and important so that when you meet with a specialist or even go to the ER for an urgent issue, you'll have all the information at the ready for the healthcare provider. And this includes, I think, research recent discharge summaries, and that could be from, recent discharge from an ER or hospital, or even like your yearly visit with your specialist, because in that is going to give you a summary, a very quick read to that doctor that you're encountering maybe in the ER, and we'll have a list of your medications and just describe what your disease is and all the recent lab reports and the imaging studies. And it should actually have the doctor's contact information so that, an ER physician could just pick up the phone and ask your doctor, if available, about your specific disease. So it enables patients to bring very targeted information to appointments, making consultations more productive or ear visits more productive, and ensuring that nothing critical is overlooked. Let's talk about the reframe. Many patients feel powerless or overwhelmed within the healthcare system, and reframing this mindset involves shifting from I have no control to I am my own very best self advocate. Now, I know that seems sort of maybe simple and trivial, but honestly, just acknowledging that shift can change everything. And it encourages patients to view themselves as proactive participants in their healthcare journey, and it transforms their role from being passive to empowered decision maker. And it can be, I have seen in my personal experience, to be very impactful. All right, let's talk about scripts, just like the very tangible things to reach for when we're not sure of how to communicate our needs. I'm just going to give you some quick examples here. What other treatment options are available? Now, I know that also seems very basic, but I am familiar with a handful of cases where this was not clearly disclosed because maybe the question wasn't asked, and it led to very invasive procedures that weren't actually necessary. And I actually had a personal experience with this. Um, I'll share it, I guess, very quickly. We were in the hospital, and my daughter had something in her brain that showed up in imaging, and they weren't sure what it was. Was it infection, inflammatory? Was it a tumor? They just didn't know, so they wanted to biopsy it. That requires craniotomy and basically filleting half her brain just to get a sample. And I asked them, that's hugely invasive. Do we have any other options? And at the time, they didn't know because they really had no idea what was going on. So I decided to ask a second opinion, and our second opinion thankfully recommended that we do conservative approach and we just follow the finding serially on MRI. And so this avoided that very, very invasive surgery. Another question you could ask, just very basically, is can you explain the risks and benefits in plain language? Sometimes a lot of this is glossed over, and just asking it in that phrase can be helpful. Additional scripts can help teach patients how to manage insurance-related issues like, my insurance denied this claim. Can you help me understand why and what I can do? That simple question is rarely asked. Or you can say, can I appeal this decision and what documentation do I need? This empowers patients to actively challenge or navigate health insurance hurdles, ensuring that they get the coverage and support they need. And this often requires partnering with your doctor actually to get the letters and the necessary documentation for those insurance companies. And finally, I just wanted to share that scripts to summarize the end of your office visit can be very clarifying because there's a lot of information shared. And so if you're not fully clear of what's going on, you just want to summarize it for yourself, you could just say something like, okay, so I will take this order to schedule my MRI with contrast 6 months from now to see how my body is responding to the medication, just to see if your understanding is correct and if you got those details right. And then you ask, how will I be notified of the results? Because a lot of times we just sort of plan for these tests to happen and we don't always know how to communicate those findings, especially if that changes management. And sometimes patients leave visits feeling unsure about what to do, and they leave with more questions than answers. So I think this is a really good sort of empowering tool to do at the end of the visits. And just as a side comment, I mentioned the MRI specifically is because a lot of times patients are given these orders, say, oh, schedule your MRI. And then you call and the schedule says, well, is it with contrast or without contrast or both? And everybody is very confused. So it's good to just ask your doctor what the situation is, because it's also good to know in your head that if you get contrast, you're going to get an IV before you go into the MRI. That also extends the time. But if you're somebody with difficult IV access, like my daughter is, we have to make sure she hydrates well with water and she's fully mentally prepared for that needle. Moving on, let's talk about the insurance management because managing insurance denials is a critical component of advocacy. Patients should be encouraged to understand their coverage policies, keep records of prior auths, approvals and denials and why, and all of the follow-ups. Because learning how to appeal denials by collecting all the supporting documentation helps to like reduce the burden of worrying about whether or not you're going to get the treatment that you need. And it can make a substantial difference mentally and in the reality of your care. And here's the crazy thing. Few patients appeal these denials, less than 1%. I've really found that shocking. And even though a substantial amount of those appeals are actually successful, like up to 83%, depending on the studies that you read, but all the numbers are very compelling. Like the percentage of success people can experience after appealing even the first time, but I appeal up to 3 times. I mean, I have found success if you just keep at it. And so also, a lot of people don't know that there is an external review process where a patient can ask for an independent third-party review, not from the insurance company, to review and decide whether a denied claim should be covered. This is actually a federally guaranteed right under the Affordable Care Act for most healthcare plans. So it's something worth keeping in mind. Let's now turn to allyship and community support. Encouraging patients to bring trusted friends, family, and advocates to appointments offers tremendous things. And they can take notes, they can help ask questions and help you walk out of that interaction with greater clarity and confidence. Also, connecting with rare disease community groups or cultural groups often provides peer coaching and shared strategies for managing appointments and insurance challenges. Peer networks often have practical tips for organizing medical data and handling complex insurance issues, making the journey feel less daunting. Now, I know that we are also having talks from people from NORD, the National Organization of Rare Disorders, and I know that they will be getting more in depth into accessing training and tools to help you understand this process more. So I'm going to conclude this section on individual self-advocacy with this. If systemic equity is about redesigning the system and provider equity is about changing how care is delivered, then individual equity is about equipping patients with the tools to be heard, respected, and believed. Equity in healthcare is only complete when patients are able to sit at the table as full partners. So let's pull all of this together now, the flow and the story arc. At the systemic level, the top of our story arc is the big picture barriers, policies, insurance coverage, geographic disparities that affect everyone. These are structural issues that influence how easily people can access care, get diagnosed, and receive treatment. The provider level is moving closer to the human side, and we see how biases, communication gaps, and trust issues between providers and patients deepen these barriers. Building trust and training providers to see beyond bias is crucial to ensuring equitable and compassionate care. At the individual level, at the core, patients are actually at the core of all of this. Their agency, resilience, and voice. Empowered patients who understand their rights, organize their data, and effectively communicate can advocate for better care and influence outcomes. Their personal power can help bridge some of the gaps created by systemic and provider level issues. So this integrated solution by this like triangular visual that I've created here, I want you to just imagine the triangle where each corner represents one of these levels, the systemic, provider, and self, the patient. And each side of the triangle supports and strengthens the other. So here is the vision. This integrated approach leads to systemic reform with more equitable policies and faster diagnoses. Well-educated healthcare providers who deliver bias-aware, equitable care. And empowered patients with stronger voices that demand better outcomes. When these pieces work in harmony, everyone benefits. So that little boy in rural Texas whose parents drained their life savings trying to get tests that insurance refused to cover, by the time he was finally diagnosed, his disease had already ravaged his body. That's what happens when systemic inequities decide who gets care and who doesn't. There's a young Black woman who repeatedly went to the ER only to be dismissed that it was just stress every time. And it wasn't until her autoimmune condition left her partially blind and paralyzed that she was finally able to get the care she deserved. That's what happens when provider biases, silent patient voices, and assumptions override the truth. These stories are painful, but teach us where the system is broken, and more importantly, where we can rebuild it stronger. So, in closing, when we work together, Reforming systems to address inequities, training providers to practice cultural humility, and empowering patients, your diagnostic journey is no longer a nightmare of delays and disempowerment. It becomes a process that is safe, timely, and equitable. When we transform care at all three levels, equity isn't just a dream, it becomes the standard of care. So, thank you all for being here. As a parting gift, I wanted to offer you a free PDF of more scripts to use in with your healthcare provider and to join my newsletter if you'd like. I know I had offered a few scripts in the talk, but I made a list of more just to help you feel more empowered in your encounters with your healthcare providers, especially if you're feeling dismissed or unseen. So you can scan this QR code to get the free gift. You would just confirm your email and then receive the gift in your inbox. Let's stay connected. Here on the bottom is my LinkedIn social handle at Maggie Kang MD, but that's also the same for Facebook and Instagram. I provided my website if you want to learn more about what I do and who I am. And I have a lot more information about, or a lot of the information I already talked about today in my blogs if you want to read more about it. And finally, I included this last fun slide because I noticed that there are a lot of people on this panel we have encountered on our rare disease journey, including Carter, who's in the upper left-hand corner with my daughter Nell at the Rare Artists event. And then also here we have Nate Milam with Nell and the CEO of Every Life Foundation. Nate and Nell co-emceed the Rare Voice Awards in Washington, D.C. last fall. Also, on the lower left, I spoke on a panel at Nord, and this was us at the event. And basically, I also wanted to share that the rare disease journey also has its perks. We have met incredible people on our journey, many friends and family supporting their loved ones, and even famous leaders like Joe Biden here, who Nell had met at Children's National. And up on top in the right corner, we met the amazing Senator Amy Klobuchar, who co-chairs the Rare Disease Caucus. My daughter was speaking at the Rare Disease Caucus at the last Rare Disease Week. And finally, if you come to Rare Disease Week, I would love to meet you all. Nell and I will be sitting at the Virginia table. And that's it for now. Thank you so much.